uh, inviting us to talk about osteoporosis in fractures. So it is very timely that our discussion about degenerative scoliosis together with osteoporosis, and we will probably try to re-examine again treatment of osteoporosis. So this will be the outline of my lecture. And first and foremost, osteoporosis is a systemic skeletal disease characterized by low bone mass. It has micro-architectural deterioration of the bone. And it happens that there will be one fracture in every 3 seconds. So as we are eating right now, there are fractures happening all around the world. So with that one, we try to see the balance of the osteoclast and osteoblast. With this one, with the understanding that with an increase in osteoclast activity, there will be osteoporosis. Bone loss accelerates after menopause, not only in the cortical bone, but also in the trabecular bone. So in the cortical bone, as you can see, the diameter of the entire cortex is not increased, but the inner diameter increases. So it leads to a decrease in the bending stiffness. In the cancellous bone, you also see that there is a lesser trabeculae, thinner trabeculae, and there are breaks in the interconnection of the trabeculae. That said, the worldwide impact of osteoporosis is very big, and in fact, in Asia, it is bigger. It is expected to increase by 2050, probably maybe because we are not very aggressive in screening our patients, especially when they become menopausal. And here is a key fact in the Philippines. 2019, we examined that there is approximately 8.6% of osteoporosis in the entire population. And it is expected to double by 2050 if we do not do anything. So the difficulty in treating fractures of osteoporotic fractures is really the patient itself. So these patients have a lot of comorbidities. They have cardiac problems, they have renal problems, which is a very big problem to begin with. And to top it all, even if you have the best implants available, then there will be no purchase of the implants or prone to failure of the implant. This slide shows you that even if you use a locking plate for that matter, the top of the line locking plate, you will still experience a certain implant failure because the working length is already decreased because of the thinness of the cortex. This is an example of a global demineralization happening of the distal femur, both the cortex and the metaphyseal area. So when we try to see the changes even in the metaphyseal area, the cancellous area, you will see that on follow-up that there will be certain voids. There will be non-union. So there will be fractures eventually, peri-hip area. And so we ask the question, whenever a patient comes into our clinic, like, who are these patients who are prone to have osteoporotic fractures? So these patients come into us with a hunchback. They are decreasing in height. They have a history of back pain, prolonged back pain without any major trauma. They had to have a previous history of fracture over the hip or surgery, or they are renal patients. These are just examples of metaphyseal comminution, the usual presentation of a comminuted fracture if they have osteoporosis. And so right now we have the available implants, we have available techniques to increase the pull-out strength of spine implants. We augment with cement. If we have a poor purchase, more often than not, if I have a very osteoporotic patients, I would ask my implant agent to bring in bone cement. So if I encounter intra-op that the purchase is very soft and I don't want to increase a level above or below, then I would just put in a bone cement. For fractures, still the same. You can put bone cement around the implant. There are newer implants wherein after putting the implant, you can still inject bone cement toward the hip and the femoral head. And intramedullary devices. These are better options as compared to your plate system because they are load sharing as compared to the plate. And so the question always of hip surgeons or even us general orthopedics, when we see fracture, should we fix or replace? This is a relatively old study, but it's a meta-analysis, and they were saying fixation is still a viable option, okay? But arthroplasty these days are very common since you don't need to wait for the healing of the fracture. So it really depends. And they were recommending hip replacement if it's already very displaced. So that said, these are just examples of how to not get more problems intra-op while treating osteoporotic fractures. So we have to bear in mind if we have to use a clamp, not to press it too hard, otherwise it will be crushed. You don't use lag screws within your plate, otherwise you will experience a very rigid fixation, thereby having a fracture peri-implant. This one is another technique wherein there was a failure after putting a plate distally, and they would suggest using an IM nail instead. So this one is a post-total knee replacement patient, and they advocated a MIPO approach so as not to devoid the blood supply of the fracture site, and eventually it healed. So there are a lot of techniques, and this one is a 40-year-old female chronic renal patient with a BMD of -7. So even if they used the best quality implant for total hip, eventually it's still fractured. So the problem is really osteoporosis and not the technique, not the implant. So we go back. It is an unregulated rank L expression that increases the bone resorption and it leads to osteoporosis. So we have to bear in mind in this freedom study that they conducted, placebo versus Prolia. After 3 years, they found out that it actually demonstrates the lesser fracture if you give Prolia for 3 years. And it actually improves, it lessens the fracture risk over the spine more than the hip, okay? And going back to the older class of anti-osteoporotic, bisphosphonate. Now, this one will inhibit and bind at the bone surface. Likewise, the Prolia is a first of its kind that inhibits osteoclast formation, function, and survival. So the effect is more systemic in nature. So you get more of the effect rather than the bisphosphonate. So these are just guidelines on when to start your Prolia. This one also. So other countries are very strict with the guidelines as to when to start with this one because it's non-reimbursable by insurance. But I think in our practice, we don't have that much problem. So it really depends on what guidelines you want to follow. So they did an extension of the freedom trial. Instead of 3 years, they made it to 10 years. And they found out that it actually reduced the fracture risk and improved the BMD eventually without any complications whatsoever. So what is our role as surgeons? So we see the patients and we can educate the patient about the fracture fragility. So I hope we have to emphasize more about how to treat osteoporosis and not just treat the fracture. Thank you very much. Any questions?
Thank you for the invitation to speak